Welcome to my third episode of my podcast. I'm Dr. Suj. I'm here with one of my brilliant obstetrics and gynecology colleagues, who is a fertility specialist. Now, we're still so early on in the days of this podcast that it still doesn't have a name. And let's hope that today has fewer technical difficulties compared with the previous two episodes. But I have fielded once again a whole bunch of questions from you guys, and we'll run through as many of these as we can. But first of all, let's just hear a bit about you, Maria, and a bit about your journey.
Hello, everyone. My name is Dr. Maria Oiconomou. I'm an obstetrics and gynecology consultant, and I'm a subspecialist in human reproduction and infertility. I had the pleasure of knowing TRUTH for a very, very long time. My being here is a very happy surprise that he invited me. And my journey throughout the years has been always about helping people. Ever since I started training in obstetrics and gynecology, I wanted to help people who were not parents already become, and whose dream was that. I trained at Chelsea and Westminster Hospital. I subspecialized in infertility. And now I practice obstetrics and gynecology both in Greece and the UK. And I think my dream is to help every couple that approaches me with accurate advice and information throughout the internet or with appointments or you name it, so that they can obtain this much wanted pregnancy. It's a happy journey most of the times. However, it's also a very stressful journey for the couples that have to deal with hormonal problems, fertility problems, many women that have to face endometriosis, many gynae problems. So I think this podcast is a very good stepping stone for women to get accurate information and the help that they need. So thank you for the invitation.
Well, thank you for coming on. Before we move on to the actual fertility side of things, I remember, so we used to work together a long time ago. You were one of my favorite registrars. And I remember distinctly, you said to me once, if I don't train you well, then you're going to give us shit referrals when you're a GP. And I found that...
That's the truth. I mean, many people don't get the correct referral because your GP is not gynae trained, and they wait for ages to get the correct referral. And I've seen many of your questions that people have addressed this podcast is that they have problems and their GP does not refer them to gynae. So we need to train you better.
Well, you have trained me, so I try and make sure that I'm up to date on latest guidelines and things like that as much as I can. But your journey to becoming a fertility specialist, you went through surgical training before, right? It wasn't just you suddenly decided to become an O&G doctor. You went through surgery. So what was that pathway like?
So in order to become a consultant in obstetrics and gynecology, you have to train both in a surgical capacity and in a medical capacity. And throughout training, you can choose on which area you want to focus and which kind of surgical subspecialty inside gynecology you want to choose. For example, there's people that deal with urinary problems in gynecology. They're called urogynecology. And there's people that deal with endometriosis, and they're called endometriosis specialists. There's people that deal with fibroids, and they're called fibroid specialists. There's people that do laparoscopic surgery for many benign diseases, and including fibroids and endometriosis. And then there's people that do cancer surgery, and they're called gynae-oncologists. So basically, because my main goal was to become a fertility specialist, my surgical skills involve dealing with patients that have endometriosis and fibroids, tubal problems such as hydrosalpinxis, thiosalpinxis, adhesions from previous surgeries, anything that might damage the ovaries, the uterus, and the pelvis, and might restrict one's fertility.
Okay, fair enough. Let's start with endometriosis because you've mentioned that a couple of times.
The reason we keep mentioning it is because endometriosis was a very much unrecognized disease in the past, and now we know that they go hand in hand with fertility. Endometriosis has two basic pillars. One is that it's a very painful disease to have, and women have suffered for years without us, gynecologists, recognizing the disease and giving them early and appropriate treatment. And the second thing is that until recent years, we were very much oblivious to the fact that it has such a great impact on one's fertility. So we see women, and you've met many patients, and you've seen patients on your TikTok account, on your Instagram, on your podcast, that suffer from endometriosis, and they have all this pain in their lives. They don't have a quality of life. They can't have children because there's lack of information, lack of proper treatment, and there's no personalized care, unfortunately, these days. Or at least we are getting there. It's just that the vast majority is not there yet. There are treatments these days. There are specialized centers. There's people doing a lot of work around endometriosis. It's just that this is recent years, and there has been many incorrect diagnoses in the past.
So the thing about endometriosis is that it blows my mind that it affects around 10% of women, and we still don't know that much about it. Like I've done some reading into the different possible causes, and there are so many things that are theorized to cause it, but none of them actually necessarily make sense. Like the retrograde menstruation side of things, that affects 90% of women. So that probably isn't going to be the cause for endometriosis, is it? Is there any of these potential theories outside of probably genetics where you think that the research might guide us into finding out what the cause is?
Unfortunately, to this day, there are like 7 or 8 factors that we think might affect endometriosis. There's proteins in the molecular level that we are studying. There's a very recent paper in Fertility Sterility in May 2024 that said that endometriosis is probably an inflammatory progress and process that takes place in the body, and they're trying to find which pathways are being activated through the process so that maybe we can find a medication that might reverse the situation or might stop it from progressing. But if we are being honest, we don't know. We are having theories, but to this day, there is no specific reason. Yes, retrograde menstruation was the first hypothesis, but if you scan a patient during her period, you will find fluid inside her tummy, and this is blood from her period, and that's normal. And many women have come to me and asked me, okay, the blood from the period flows back inside my tummy. Why do I have a cyst? The cyst is not an inclusion cyst. It's being born in my ovary. So probably that theory is not for deep infiltrating endometriosis. To this day, if you're being scientific, you can't really answer this question.
Yeah, I mean, and I think that's really heartbreaking, because the way that it affects women with the debilitating pelvic pain, the chronic pain that doesn't even have to happen during periods. What treatments do you see that work best?
It depends on which phase in life the patient is at. So if it's a woman that has completed her family and she suffers with pain, then more radical surgery needs to take place, and we shouldn't deprive her of the opportunity to have radical surgery from a specialist in endometriosis, not just any VGH, not just any person with laparoscopic skills. The patients that have deep infiltrating endometriosis need to have proper surgery, not laser surgery, not just cyst aspiration. They need to have proper excisional surgery from an endometriosis specialist. And this is something that when I worked at Chelsea in Westminster, they had a proper endometriosis service. There is a big change now in the NHS. They're trying to set up centers to have proper specialists that can operate on these women, because even if you get surgery and you get it by a person who is not trained to deal with the disease, then you end up with a worse outcome. You have like a very small amount of regression of the disease right after the surgery, and then it keeps coming back if you haven't excised it properly. So we need specialists that can treat the disease and that they have been trained to treat the disease. Apart from surgery, though, because there's women suffering from the age of 18, 19, 20, 25, 35, and they haven't completed their family planning, and they're still wishing to have children, but they don't want to live with the pain. We know that as per NICE guidelines and the RCOG and even ESRE, the European Society of Reproductive Endocrinology, endometriosis is an estrogen-dependent disease. So women who have estrogen, which is every woman before her menopause, will have flares of endometriosis. And we know that the most ancient medication for that was GnRH agonists. However, you can't take them for very long. You need ADVAC therapy, you need Tibolone, because women, if they take GnRH agonists for very long, they might end up with osteoporosis. They might have problems with their libido. They might experience an artificial menopause, hot flashes, night sweats, and then it also ruins their quality of life as much as endometriosis does. So women who are diagnosed with endometriosis at an early stage in life, they should meet with two people. One is a fertility specialist to explain to them how endometriosis damages the ovaries and their egg count, and they should be offered egg freezing. The NHS at the moment does not offer elective egg freezing for cases with endometriosis apart from people with cancer, which is a bit unfair if you're asking me, because yes, cancer survivors should be offered egg freezing, fertility preservation before getting permanent treatment for cancer, but endometriosis also is making them handicapped, is also depriving them from their fertility. It's a known factor. We should be able to push the CCGs to offer egg freezing, elective egg freezing for patients with severe endometriosis. We should put it in the criteria. I mean, it's not up to me, but it's just a recommendation from a patient, from a person seeing all these patients and how this has an effect on their egg count. And I mean, it's not only me, it's every fertility specialist who understands endometriosis. So in terms of treatment, yes, they should be able to discuss with someone about preserving their fertility. And then after having preserved their fertility and frozen some eggs or embryos, if they have a partner and they're not ready yet to have a child, then we should discuss surgery.
I wanted to just take you back to when you said that endometriosis damages the ovaries and reduces the egg count. Do we know a mechanism for why that happens? Because I know that endometriosis leads to subfertility, but I've never really understood why that happens.
The key mechanisms of how endometriosis leads to subfertility are a few. First of all, endometriosis can be categorized in stages. And based on the stage, you can correlate it to some kind of infertility. What I mean is, if someone has endometriosis in their pelvis, because it's sticky blood, that it's called a chocolate. It's chocolate-like. So it can cause tubal adhesions. It can close one's tubes, thus making it impossible for the sperm and the egg to meet. And this is endometriosis in the pelvis by an occlusion mechanism. Also, endometriosis damages the ovaries because, first of all, the cysts that are called endometriomas, they take space from the ovary, and in the space where healthy eggs would be growing, the cyst is growing. So our egg count gets diminished, and women cannot have the opportunity to become mothers later in life because the endometrioma, the cyst which contains the endometriosis, has taken the space where their follicles would have been. Also, many women will have endometriosis on their bowel or posteriorly to the uterus, and they will experience dyspareunia, painful sexual intercourse, and they might not be even able to tolerate sexual intercourse to become pregnant. Especially on the days when they're ovulating, we have our ovulation pain. Imagine having the pain during deep penetration. So that makes it impossible to conceive. Also, endometriosis goes hand in hand with a condition called adenomyosis, which is a formation of endometrial tissue in the muscle of the uterus. And this makes the periods very painful, very heavy. It makes the uterine muscle more floppy, if you want. So these people have secondary infertility because of the uterus as well. But the main mechanism why endometriosis is damaging our fertility is that it lowers our egg count from taking space on the ovary and from producing adhesions, thus making the tubes useless.
Wow. So then if you let's say if we diagnose an endometrioma, and then would treatment for that be excision in the same way that in adenomyosis would we excise the endometrial tissue from the muscle wall?
You can't excise adenomyosis. There's no actually treatment for that. But for an endometrioma, there's actually criteria on when to operate or not. So ESRE says that if an endometrioma is larger than 5 centimeters, then the woman should have it excised. What we say as fertility specialists is that every woman, before she decides on surgery on her ovaries, irrespective of the pathology, even if it's for a benign cyst that's not an endometrioma, or if it's for an endometrioma, I'm not talking about malignant disease because that's a different conversation, should have their anti-Mullerian hormone, AMH, measured, and then we decide based on that. If you have a high AMH and the woman is very young and the endometrioma is very big, then we can have it excised. But if a woman wishes for fertility in the near future and her AMH is low, then we might consider egg freezing or embryo freezing before excising the endometrioma. The reason I'm saying that is because when you excise the endometrioma, no matter how good the surgeon is and how much the technique is soft and smooth, with the cyst, there will be some healthy ovarian tissue coming off as well. Even when you do hemostasis during surgery, you will also burn a part of the ovary and you will damage healthy ovarian tissue. This is the normal process during an endometrioma removal. Irrespective of how careful the surgeon is, you might have a blood vessel bleeding, you might want to cauterize something. So ideally, we should know what the woman's AMH is before surgery and before deciding on whether to perform surgery or not. We have to take into consideration both fertility and the surgery.
Okay, fine. You mentioned that you don't excise adenomyosis. So I know that the treatments for it can be analgesia, hormone related, and I think the only definite cure is a hysterectomy. Is that right?
Yes, that because we don't go around removing women's uteruses. We don't castrate them like that. It's not good. We usually use progestogens. We might use the Mirena coil to help it become a bit smoother and to alleviate the symptoms of heavy bleeding or pain. And then if this persists and the woman does not need her uterus anymore in terms of baby making, the house for the babies, then we will consider hysterectomy, yes. There have been some kinds of endometrial ablation as well, but ablation is only inside the lining of the uterus. So again, it's not proper treatment for adenomyosis. The gold standard is a hysterectomy.
I get a lot of people in my comments talking about how they've had adenomyosis for a long time and also endometriosis, and they both together cause debilitating pain, and they really, really, really just want a hysterectomy. Often they comment saying that their gynecologist says no. Why do you think that is? I mean, I think I kind of understand why it is. It's because even though people may not want children now, we don't know if they would want them later. But a lot of the time I see comments and videos about women saying they are 100% certain that they will never, ever, ever want a child. So in those situations, how come the autonomy is taken away from the patient?
I am a bit torn about this question because these days treatments are always in favor of what the patient wants. We practice medicine these days with having patients who are well informed and who take part in the decision for their treatment. I mean, if you accept cancer surgery, where, even in cancer surgery, the patient can decline treatment or can ask for a specific treatment. But I think because adenomyosis is a very particular disease in terms of being recognized or being over-recognized or being under-recognized, and it has very limited criteria and minimal diagnostic tools to diagnose it. You can see it on the MRI, you can see it on the ultrasound, but it's so and so. It's not like you see a cyst and it's a well-formed cyst and you say, that's it. You have to correlate symptoms with imaging to diagnose adenomyosis. And because a hysterectomy, which is the ultimate solution, has many known complications, such as ureteric damage, bowel damage, losing of one's libido, having vaginal atrophy, having painful sexual intercourse afterwards, having the need for a blood transfusion. So I think that many doctors will balance the possible complications of a hysterectomy with what the patient will gain from having a hysterectomy and whether this can be treated in a more conservative way, such as giving them a Mirena coil or giving them some kind of hormonal treatment. And because these are minimal risk for the patient, they pose a minimal risk for the patient, I think many doctors will decide that this first line treatment is less dangerous for the patient, and they can always go back into stopping hormonal treatment. They can remove the Mirena coil, they can have the uterus back. And I think that from experience, we've seen women losing their uterus and feeling like they lost a part of themselves. It's the equivalent of a man losing a testicle. I mean, it's our feminine organs, the uterus, the ovaries. I can understand why some people might have second thoughts, but if a patient has decided that this has a severe impact in their life and that they can't go on living like that, and they understand that they might have the surgery and they might still have to live with the pain, because adenomyosis is not a definite disease. It is a disease, but it's not a definite cause of their pain. I think that the patient needs to understand that they might have a hysterectomy with preservation of the ovaries, and they might still have pain from an underlying endometriosis. So this is something that we need to work on our communication skills with the patient. And of course, if the patient still feels like that and it has an impact on their quality of life, then yes, we need to seriously consider a hysterectomy. You can't decline a treatment that is well recognized and it's on the guideline, let's say, because you think that the patient might be better off without it. Yes, you need to advise them that my personal opinion as an expert in this and this and that is that you are off better without a hysterectomy. But if you have diagnosed for sure adenomyosis and you think that this patient has a bad quality of life because of it, and you've tried the Mirena coil and it hasn't worked, and you've tried the hormonal way and it hasn't worked, then yes, we should consider a hysterectomy. We can't deprive women from that service, since we doctors have put it on a guideline, they're gold standard.
So I've seen, I remember speaking with an endometriosis specialist who said we would, in some cases pre-hysterectomy, we would try and give high dose hormones to, I don't know which hormone, but to try and kind of stimulate a menopause or simulate a menopause even. So that you can then see if we do a hysterectomy or if we remove everything, will the symptoms resolve? Can you just, I don't fully understand that. Would you be able to, can you shed some light on it? I hope I've given you enough information.
So the medication they were talking about, I presume it's DNRH agonist. So you give someone a medication that acts in the hypothalamus, in the brain, and you cut off completely the supply of hormones to the ovary. So you deprive the woman of estrogen, progesterone, and testosterone, which are the main hormones in our body, the main female hormones in our body. So you try to see whether, if the woman did not have any hormones, whether that would settle her symptoms. And if she doesn't have any hormones and that makes her have no symptoms, then you would consider treatment. But the uterus is not an organ that produces hormones. The uterus is just a muscle bag. It's a muscle bag that is there to help us have a baby. The uterus does not have any other purpose in life. It is only there to have a baby. It's not a hormonal organ. It does not produce hormones. We don't need it for anything else. And the fact that we see a period is the result of us not being pregnant. This is why the uterus is there. It's not there to produce some kind of hormone. The cervix might have a thing to do with our orgasms, and some people might get an orgasm from the nerves in the cervix, but the uterus is just there to carry babies. And unfortunately, I'm very pro-feminist. I don't think that all women should have a child. I think that women should have the option whether they want to have a child or not. But the uterus itself is an organ that exists there to carry. It's not a hormonal organ. And the reason I'm putting emphasis on that is that even if you put a patient on a menopause and you deprive them of their hormones, you might see whether they suffer from a hormonal imbalance or endometriosis or adenomyosis. But you then have to remove their ovaries as well if you want to give them definite treatment. It's not just a hysterectomy. If you put them on a technical menopause and you find out that hormones is their problem, then you have to remove the ovaries. And the question is, and many endometriosis specialists have the same question, you put them on a menopause and you understand that, let's say that I have endometriosis and you put me on an artificial menopause and I'm doing much better. So you have to remove my ovaries, but I'm 35. The question is, you remove my ovaries and then you have to put me on HRT because I will develop osteoporosis. I will double my risk for cardiac events. I will double my risk for having a stroke because of the lack of estrogen, and I will have no libido. I will not be able to have sexual intercourse. But putting me on HRT means that you're going to give me estrogen again, the same hormone that I had before, and it was causing problems with my endometriosis. So it's like a vicious cycle. You have to be very careful who you operate on. I think that so far the best solution is not a castrating procedure. It's a procedure that is well designed, a meticulous procedure by a very careful specialist that will remove the endometriosis from a patient's pelvis, but not her vital organs. That way, yes, there will be excisional endometriosis surgery. You will have all the disease removed. You will be put on an artificial menopause for an X amount of time, usually 6 months. But then you probably will have the time to heal, have the time to bear children without losing your womb or without losing your ovaries. And probably eventually, if you complete your family planning, then yes, you might as well get, and you are over the age of 45, so that you get all the merits of having estrogen until that time. You will probably get proper surgery and remove all of that and discuss about whether you're going HRT or some kind of add-back therapy without estrogen, not to have the risk of a flare of endometriosis later, like Tibolone.
Interesting. Okay, so then if we go back to hormonal treatments for something like endometriosis, I've had comments on my videos asking, doesn't the estrogen component of the combined pill feed the endometriosis and make it worse?
It could have, but because it's balanced with progesterone, it does not allow your ovary to produce any. It's very minimal. The amount of estrogen inside the pill is minimal. So it does not allow for flares, and it does not allow your ovary to function and produce while you're ovulating an extreme amount of estrogen, especially for young women who ovulate properly and they have a huge amount of estrogen. So you don't have actually any circulating estrogen apart from the one in the pill, which is minimal. And actually, because the combined pill has an impact on the brain as well, you don't secrete your own estrogens, your ovaries become small while you're on the pill. And it takes about 6 months for the ovaries to recover. And that's why we tell patients, if they want to measure their fertility, they should stop the pill for at least 6 months before measuring their AMH or doing a scan to see their follicles. So the pill, although it has a small amount of ethylene estradiol, it downregulates the ovaries completely. It does not allow them to produce their own estrogen. Yes, you have some circulating estrogen in your bloodstream, but this is completely artificial. It's not that the ovary works and produces estrogen, and this is the estrogen that actually makes the endometriosis flare.
Why do people who are on the combined pill for a prolonged period of time, why do their periods become much, much, much lighter and much shorter as well?
Because they're not proper periods. What I mean proper periods, let me explain myself. There's no such a thing as a proper or improper period. How our body works is that women of reproductive age have a specific number of eggs on their ovaries. Each month it's a different number, but on average it's almost the same every month. And the number changes with age. It becomes lesser and lesser and lesser. What happens every month is that the ovary thinks about it and says, okay, I'll pick an egg. She picks an egg. And that egg is our dominant follicle. So it starts growing right after our period and it produces estrogen. And around the middle of the cycle, for a 28-day cycle, that egg will pop and the follicle will pop and it will release an egg. And this is our peak estrogen. So that egg will fall inside the tube, and if the egg meets with the sperm, then there will be an embryo and it will implant in the uterus. However, when the egg does not get fertilized, we form the corpus luteum, it gets absorbed, and then right on the time of ovulation, the uterus will be very, very thick because of the high estrogen that our ovulation has produced. So the lining that becomes the period is the blood that gets formed to receive the embryo. So our peak endometrial thickness is during the time of ovulation. And if this does not welcome an embryo, that inside the lining becomes our period blood. So a woman that has a proper ovulation, high estrogen, or is very estrogenic will see a heavy flow in her period. What happens while you're on the pill, the ovary has the eggs, the follicles if you want, and she doesn't use them. It's sleeping. The pill puts the ovary to sleep. So the mechanism of contraception is that you don't ovulate. Your ovary does not grab an egg. It's sleeping. It's not maintaining the eggs. The ovary loses egg every month. Our egg count still goes down, but we cannot ovulate. We don't have an LH surge. We don't have an FSH surge, which are the hormones from the brain that go to the ovary. And because our follicle does not ovulate, we don't get thick lining during the middle of the cycle. The lining gets thick because of the estradiol component of the combined pill, which, as I said before, it's minimal. So you will see artificial periods. The blood inside the thickness of the lining will be minimal because the pill is what's creating your period, not your ovulation. So it's very, very different. And sometimes you might see spotting, especially in the first months of the pill. That might be regular, then it might be mid-cycle. But still, the period that you see while you're on the pill is a result of you getting estradiol from the pill. It's not a result of ovulation, and that's why it's like that.
Fine. That's so interesting. So then when when someone's on the combined pill and it's inhibiting their ovulation, why does that not preserve their egg count?
Well, women are born with approximately 700,000 eggs. All of us, irrespective of our eyes, skin color, place of birth, habits, we are all born with the same number of eggs. And once we reach the age of 14, 15 years old, once our first period arrives in life, we know that 300,000 primordial follicles are lost. So every woman starts her first period in life and the journey that is called reproductive year with 400,000 eggs. And what we also know, another milestone, is that during the time we are menopausal, we don't have any egg left. However, every month, imagine our egg storage like an iCloud. Yeah, every woman has a cloud on top of her and it's full of eggs. However, and we get the same starting point. However, every month the ovary downloads from the cloud a specific number of eggs, and that is different for every woman. Some women might get more from their storage and they might lose them. Some women might get less. Some women might have a steady amount of eggs coming down from the cloud every month. But every month the cloud sends to the ovary, irrespective of whether the ovary is using them or whether the ovary is not using them. Imagine, even if my ovary had 20 eggs on it, I would only be using one. The ovary is programmed to lose eggs every month on a monthly basis. And I know it sounds like the ovary is actually losing them. It's not just the ovary, it's a genetic thing. Women are programmed to lose eggs every month, irrespective whether these eggs are useful, whether they get fertilized, whether they are slipping from the pill. We lose eggs. That's a definite. We cannot reverse time. So a woman who is 25 years old without a genetic predisposition to an early menopause or any other genetic factor, a woman who is a healthy 25-year-old should have more eggs from a healthy 40-year-old. I'm not talking about quality, I'm just talking about numbers. There are 25 years old patients that have a very depleted amount of eggs, but that's due to other conditions. But ideally, a 25-year-old should have many, many more eggs than a 35 or a 40-year-old. And this is the basic element of why we lose eggs. It's an age thing, it's a time thing, and this is why all of us fertility specialists are screaming, freeze your eggs, freeze your eggs, freeze your embryos, have a child. Don't wait until you're 40. It becomes more and more difficult.
Mm.
I myself don't have children, but I'm a very big advocate for people who want to have children or for people who don't want to have children. It's just that I think that the potential of you being able to have children, even if you never have, it's very reassuring for a woman. She can go on, have her career, she can go on, experience her relationships. It's very good to be able to preserve your fertility. Men don't have this problem. They will always have sperm. Sperm gets reborn every 3 months, irrespective of the age, irrespective of the factors that are environmental factors, whatever. You create new sperm. Women are not that lucky, so being able to preserve our fertility is a very good thing to have these days. It didn't exist 20 years ago.
Right. So then what can women do to improve their egg quality? And therefore hopefully improve their fertility?
That's a very popular question, and these days it's like a flaming subject. So we know that quantity we can't mess with. Quantity, it is what it is. But quality is directly related, first of all, to age. We can't change how old we are, but we can predict that, if my AMH and my egg count at the age of 35 is like this, I should or plan to have a child or to freeze my eggs. And that's a term of in quality terms. That means lesser chromosomal abnormalities the earliest we freeze our eggs or the earliest we use our eggs. However, women, before embarking on a fertility journey or an egg freezing journey, they can do many stuff to optimize their health, because our eggs and our fertility is directly linked to our body. So the general advice that I know that everybody's aware of, but I'll just repeat it because they have many, many coexisting factors, is that women should not smoke at the time when they decide to pursue fertility. So you should not use alcoholic beverages, or if you do use them, just grab a beer that contains a low amount of alcohol once a week. But ideally, we should not at all. Vaping is not innocent. Smoking and vaping are almost equivalent, so we should avoid both. Even if we're doing egg freezing, imagine you are freezing an essential element of your body, your eggs. They will contain the DNA that inhabits in your body at this specific time. So if someone smokes a lot, then the DNA might be damaged. We should get a sufficient amount of vitamin D. There was a paper published last year, or this year actually, about how women that had a sufficient amount of vitamin D, they responded much better in IVF stimulation rather than the group that did not have an adequate amount of vitamin D. So vitamin D is an essential part before you undergo IVF. And it also helps a lot when you become pregnant to produce smarter babies that have a big, good neurodevelopmental growth. Also, folic acid supplementation helps a lot. And then there are some theories and some vitamins that people are discussing a lot about. There's a supplement called DHEA that there's controversy around it because it's a precursor of androgen, but many clinics around the world use it these days as a preparation for IVF. And there have been studies where it has improved fertility rates, and there are other studies that say that it doesn't matter. You shouldn't get treatment before discussing with a fertility expert and before getting hormonal tests done. If you're asking me, I can't tell you whether it's good or bad. I would have to assess a patient's blood tests. I would have to see if they're deficient. I would have to see what their androgen levels are and then discuss whether they need androgen supplementation. There's a lot of papers these days about testosterone supplementation in a transdermal way, or a gel or a patch. There's a lot about DHEA, which is a precursor to testosterone. We know that androgens might help improve fertility, but since there are no large randomized studies, what I say is someone needs a bespoke fertility service. This is what each patient should be offered, tailor-made IVF or fertility. We should test your hormones, we should see if you're lacking something, and then decide whether you need supplements. You should not buy over the counter everything that you might feel might improve your fertility. There's a big market out there trying to get patients money. And honestly, there's so much you can try. I don't think it's worth spending all this amount of money without actually knowing what your body is missing. You should listen to your body, you should see your blood test, and then you should decide. There's a lot of talk around Coenzyme Q10 that it helps a lot with priming women for fertility treatments. And there's a lot of studies published. And if you're asking me, you can't over-supplement on Coenzyme Q10. So that's good for both males and females.
Okay.
And then some people are using NAC, which is also very good for body detox. It acts on the liver and it helps us do a liver detox. Women who wish to...
well, sorry, 1 second. As in the thing that we use when people have a paracetamol overdose, N-acetylcysteine.
Yeah.
Really? You use that for fertility?
Yeah.
Oh, wow. Okay. How does that help fertility?
So there's NAC. NAC does not improve fertility. NAC acts on the liver. We use it when you have a paracetamol overdose. It helps with the liver detox. And the mentality, at least my mentality before embarking on an IVF journey with a patient, is that their body is ready to have IVF. Their BMI is optimal, their health habits are optimized, their body has been through a detox phase. I don't mean starving diets, I mean healthy living. Your body will go through a marathon. That marathon is called IVF or fertility or IUI, you name it. It's a stressful process. Our body does not respond well to stress. If a woman is stressed, if a human is stressed, they can't sleep at night. Their sleep gets deranged, their hormones get deranged. You've heard of patients that were very stressed and they didn't get a period. Our hormones get imbalanced. So before you start on an IVF journey, it's ideal that we have a liver detox, that we maintain a healthy weight, that we throw out, if you wish, all the unhealthy habits that might not help us succeed. And there's plenty of supplements for that as well. We don't have to have an over-supplementation. You don't have to procure 5,000 vitamins and become a vitamin freak. It's just that we need to find out what is missing from every patient and help them go through a balanced regime before having IVF. And this is called pre-treatment, and it's very, very essential. It's very easy for a doctor to do an IVF round. Every fertility specialist in the world knows how to do IVF. It's very easy. What is difficult is to wait for the patient to have optimized their health. And this is why I think science is turning into bespoke treatment. It's not one size fits all, one treatment for everybody, one surgery for every endometriosis patient. No, every woman is unique. Every woman has different symptoms. Every woman's fertility journey is different. So bespoke solutions should be the case eventually.
So what would you say are the top things that a lady should do if they're trying to get pregnant?
First of all, learn what is the factor, who is the factor that's making you infertile. Wrong treatments will make your journey harder, and the wrong diagnosis will make your journey more stressful and more timely. So number one, recognize what is the factor. Is it just coincidental? You're having sexual intercourse on the wrong day? Or is there a proper infertility factor? Is the sperm not good? Are the tubes not working? Is there an infertility factor such as PCOS that you can't ovulate? Is there a wrong timing? Is there an anatomy factor? There's fibroids, there's polyps. Your partner can't ejaculate. We need to identify the risk factor. If you know the risk factor and you know what's the problem, then you can treat it and get on with it. If you don't know and your health provider is not treating you for that, then that's a problem. And you can't go on. I've seen patients with polycystic ovaries not ovulating for 2-3 years, and they're not being referred. This woman is not going to ovulate on her own. There's no point of keeping her at home for 2 years trying to have sexual intercourse if she's not ovulating. So number one, identify the risk factor, identify if there's an infertility factor. Number two, get a proper and timely referral. Ask your GP, where is my fertility service? What do I need to do in terms of investigations? Can you send me for a scan? Very basic things that will help us. Number three, health optimization. Stop smoking, avoid alcohol, exercise 3 times per week, eat healthy, avoid all these saturated carbohydrates, avoid fizzy drinks, eat greens, eat carrot, eat have a Mediterranean diet, try to be balanced a bit. Not that if you go out and you eat McDonald's, not that this will have an impact on your fertility. It's just try to optimize your lifestyle. Do not starve yourself. Even the other hand of the other part of the spectrum, people who are on a diet all the time, that's not healthy either.
What can a man do to improve his fertility?
That's a very nice question. So men, as we said before, have this luxury of time. Men will produce new sperm, and with an appropriate intervention, even an abnormal semen test can become normal within a matter of 3 months. Male fertility, apart from genetic factors such as Y chromosome abnormalities that we can't fix because it's in the DNA, there's many factors that a man can improve. You can try to lower your scrotal temperature. So if you're driving a lot or if you're riding a motorcycle, that's not very good for the testicles. And we need to lower the scrotal temperature. If you're using your mobile phone very close to your pocket, try not to do that. Also, diet plays a key role in implementing sperm quality. The diet must be based on nuts, greens, dark chocolate, not a lot of sweets. Men should use carotene. Carrots are very essential. Spinach is very essential. There's a lot going on with nutrition for sperm optimization. And even there's free advice on the internet about which fruit is very good and which veggies are very good for the sperm. So food intake and maintaining a healthy lifestyle. Smoking and alcohol are also prohibited. Drugs, needless to say, but I'm just going to put it out there. And vaping. And also there has been a correlation with protein powders and protein shakes damaging sperm quality. So if you're going to the gym, that's a good thing. You can continue going to the gym, but please, please, please don't take protein powders while you're trying to conceive because they have free radicals and they destroy your sperm.
Wow.
And testosterone injections, all these things that you want to get to become more muscular, please don't take them while you're trying for a baby. It lowers the libido and it destroys seminal production. So you get sperm that is not as dense. Concentration drops because testosterone inhibits sperm production. And the testicles might become a bit smaller and men might have a problem with producing an adequate and healthy amount of sperm. So overall, I would say maintain a healthy lifestyle. Try not to intervene too much with your hormones and try to lower and maintain a healthy scrotal temperature. No, don't go into hammams, saunas. I mean, you can do it for fun, but while you're trying for a baby, it would be best if you didn't.
You talked about liver detox. What do you mean by that? Because that's a term that gets thrown around a lot by people in the wellness world when they're trying to sell some sort of supplement or something, or they say, I don't know, drink put a slice of lemon in hot water and have some tea, and they say that this will detox your liver.
That's nice.
And to me, that kind of screams red flags when someone talks about detoxing the liver. What can you just explain further?
Like you very correctly said, there will be people trying to sell products for your liver detox, for your gut health, there's actually a very good documentary at the moment on Netflix about gut health and how, what you eat, you are what you eat. But I'm not talking about over supplementing yourself to clean your liver. That's not the mentality. The liver is our factory that cleans and metabolizes everything. So what I mean about maintaining a liver detox is, cleanse yourself. Don't do a radical cleanse. Eat healthily. Avoid over supplementing. Avoid getting alcohol, which is basically metabolized all in the liver. Avoid taking 5,000 different vitamins to become pregnant. These are all urban legends. Let your doctor give you, or your fertility midwife, your fertility nurse, let them decide, with your input, of course, what you are lacking in. Do not go to extreme lengths and do not get fooled by people on the internet selling, take my brand of NAC. or take my brand of vitamin C. Yes, vitamin C, vitamin D, folic acid, all these things, maybe DHA for some people, testosterone for some other people, lysine for people who have a reduced immune system. Yes, all these vitamins, they're good things, but there's a lot of bad people who are trying to sell these things. Whereas if we find what you're missing, we might actually tell you, you don't need any of that. You just need to eat in a balanced way, and you should avoid cake or whiskey. Liver detox is a way of living. It's not a program that you need to subscribe at to pay money to get supplements. Liver detox can be achieved through eating greens, through making a detox day, planning a detox day during your day, through avoiding red meat for a few days. You know, it's a thing that you can try to program your life with, but without having to buy and buy and buy stuff. My mentality is not go out there, enter a pharmacy or an online pharmacy and buy everything. My mentality is try to be healthy with exercising. Yes, involve a nutritionist. They can help you do a liver detox, but do it naturally, like in a holistic way. It doesn't have to be through 500 different types of branded vitamins.
Okay, fine. I get you. So you mentioned PCOS as a cause for subfertility, infertility. You said it leads to, it stops people from ovulating. Can you just talk a bit more about how PCOS actually leads to subfertility or even infertility?
First of all, if you're asking me, I think we've named PCOS with the wrong name.
It's wrong. It should be polyfollicular.
It's wrong. Yeah, it's wrong because I have many patients and I've been an obstetrician for 14 years now and a gynecologist. But I think that we've given people the wrong impression. The medical community tried to fool people. So
the medical community also doesn't even know. The medical community doesn't really know, because I've had people saying, I remember when we were on Gynae together, I had people trying to refer as a suspected ovarian torsion because the person has PCOS, saying they've got cysts on their ovaries. And I was just like, they don't have cysts on their ovaries. They have lots of follicles in their ovaries. It's just a misnomer.
So, exactly. So
and do you know how I know that? It's because you taught me.
I know. Thank you. I've convinced you. So there is heated debate these days about this polycystic ovary thing, because many patients will now understand what a cyst is. And they will come to you expecting to tell them that their cysts have grown or have been reduced or disappeared. Well, polycystic ovaries do not have cysts. We call them polycystic because we didn't find a better name for them. In lack of a better name, polycystic ovaries are not cystic. They don't have cysts. There are two conditions that involve polycystic ovaries, and every reproductive endocrinology doctor should be able to identify and screen for them and differentiate them. So the basis of all of that is an ovary that has too many follicles. Lots and lots and lots of follicles. When I say too many, I mean above the number of 15 follicles. Even for an older patient or a younger patient, if an ovary has a large volume and too many follicles, and this is not something that is partial, I mean more than 15 follicles, because many for me might be different for many for you. So the original idea is that the polycystic ovary has many follicles. However, now we know that there are patients that have polycystic ovarian's appearance. Their ovaries do have a lot of follicles, but they don't have polycystic ovaries syndrome. And why I say this is because a polycystic ovary, an ovary that has many follicles, does not necessarily mean that large endocrinologic disturbance that comes with the polycystic ovaries syndrome. So it's a very different thing if a patient has many follicles, and very different if a patient has hormonal imbalance, basically because they have PCOS, which is the syndrome. I'm not going to talk about the patient that has the polycystic appearance, because these patients will have a regular cycle, will ovulate, and will not face fertility problems. They don't have endocrinology issues. They don't have a hormonal imbalance. They just purely have too many follicles. The most common condition is PCOS though, polycystic ovarian syndrome. That means, again, your ovary does not have cysts. However, the PCOS, the polycystic ovary syndrome, is a metabolic syndrome. People believed it was a gynae problem. It's not. It's a multiple organ problem. It's like middle-aged people who get metabolic syndrome. It's like how someone can have a different kind of syndrome. It's called a syndrome because it affects many of your organs. Women who suffer, and I say suffer because there's many women suffering with PCOS, which is undiagnosed, not treated, not referred to the gynecologist from an early beginning, not unless you reach that point where you're struggling to have a child and you can't. However, there are women that have PCOS that do not wish to have a child, but they still have so many problems and they don't get a repair. And to summarize what PCOS is, it's a syndrome that involves the ovary, it involves the pancreas, where insulin is being produced, it involves our liver, it involves our metabolism, our BMI, our weight gain, our hormones, and our period. And what happens is, the ovaries have many follicles, and that means that there is a plethora of LH. You can see on the blood test of a patient that there is a very high LH compared to your FSH hormone. There's an excess of androgen in some people, so you can say that in the criteria there's clinical or biochemical hyperandrogenism. That means that the patient might have acne, they might have hair in places where a woman is not expected to have, and they might have a large ovarian volume, most of them, and they might have other biochemical imbalances such as insulin resistance. And that leads women to have a higher BMI than expected. That leads them to not get a regular cycle, especially if their food does not involve healthy eating, and if their calories or their complex carbohydrates and their saturated fats increase. That means that their metabolism slows down, and that means their hormones go out of control, and women don't get a period. And if you remember earlier on, we discussed that the way to get a period is for you to ovulate. If you don't ovulate, you don't get a period. So the ovary struggles to select a follicle. She struggles because there's plenty of hormones that are imbalanced, because the follicles are too many. For a number of reasons, the ovary struggles to select a follicle. For some women, the follicular selection will happen later in the cycle, thus they will get a 40-day cycle or a 45-day cycle. For some women, ovulation might not happen at all, and they will get a withdrawal bleeding once the uterus is filled with blood 3 months down the line, 4 months down the line. And you'll tell me, okay, what's the problem with that? They don't get a period, they can go swimming much easier. No, the uterus needs to set the lining. When the lining becomes hectic and very stuffy and very thick, it can lead to abnormal cells. And this is a very important factor, a risk factor for the creation of endometrial hyperplasia that might lead to endometrial cancer. So we want the lining to set. We want women to get at least 6 periods per year.
6? I thought it was 4.
Ideally, they should be 6, once every 2 months.
Oh, really? Because we were taught at medical school that it was 1 every 3 months.
Yeah, but if
Is
you
that
want
wrong,
to
though?
be
Has that
healthy,
changed?
no, it's not wrong.
Mm.
In order to avoid hyperplasia, but in order to be healthy, ideally, we want a woman to have a period every 2 months. I'm sorry,
Every 2 months,
6
fine.
times per
Okay.
year. Ideally, 6 to 8 periods per year is absolutely healthy. And you'll tell me, okay, we want that, but how should we treat? I mean, women should be diagnosed early on if they have PCOS. And I don't mean very early on, because you might see in a pubescent teenager or in a patient before their 20s, you might see hormonal imbalances that might not depict PCOS. And that is because the hypothalamus pituitary axis that connects the brain to the ovaries is not mature yet. So we need that axis, that tunnel that goes from the brain to the ovaries to become mature. And that becomes mature around the age of 20, I will say. And it's a very It's a very average age. It usually happens a few years after we get our first period. It's different for every woman, but ideally we should screen for PCOS once the patient is after the age of 20, or if they have severe features of hyperandrogenism earlier on in life, because we need to screen for other conditions as well, as you're very well acquainted with, adrenal conditions and other more rare conditions if the patient has extreme features. But around their 20s, patients should have kept a period calendar. We should know how many cycles they have per year, and we should be able to do a hormonal blood test and decide whether they have PCOS or not. They don't have to see a gynecologist if their periods are regulated, or if the GP has an interest in gynae and they can help them. And what I mean by helping them, I don't just mean giving them progesterone to bleed. I mean that PCOS is a metabolic syndrome that can be helped by getting vitamins such as myo-inositol. Myo-inositol is a well-known vitamin that helps people with polycystic ovaries ovulate and regulate their cycle. By getting a nutritionist involved and lowering their blood sugar levels, helping them process their insulin, helping them eat better, helping them reduce BMI. A large number of PCOS patients will start ovulating and will regulate their cycle once their BMI is less than 30. So dietary advice, it doesn't have to be an intervention. It doesn't have to be that we give everybody the combined oral contraceptive pill. Yes, some women with PCOS will need it because their hormones are up and down and all over the place. And the pill will mask all of these symptoms. It will not treat them, but it will mask them. However, not everybody is suitable for the pill. There's plenty of vitamins. Again, I say this about vitamins all the time. I don't mean supplements necessarily. It can be a vitamin that you take through food. It can be a healthy lifestyle. It can be that you include exercising. We know that people with PCOS, once they have a good glucose control, they will ovulate, a vast majority of them. By giving them myo-inositol, it will help. Some women will have insulin resistance and they will need to get metformin to regulate their glucose. And once they get metformin, they will ovulate. And I keep talking about ovulation because it's the outcome of this process. And it's something that you can actually see because ovulation will lead to a period. So you know that you're well regulated once you see a spontaneous period within 2 months. So PCOS, the diagnosis is a key element to treatment. An appropriate diagnosis is a key element to giving people myo-inositol, metformin, reducing their glucose levels, keeping them on a healthy diet, exercising, lower the BMI. And these days, there's extensive talk about including AMH as a predicting factor for PCOS. So large, big numbers in the AMH result means that the patient most probably has a polycystic morphology in their ovaries, but it cannot differentiate whether the patient has the syndrome or the morphology. It's just there's a lot of talk in the fertility world whether we should include AMH in the Rotterdam criteria. I mean, a different kind of criteria. The Rotterdam criteria is the current classification for PCOS, but overall, what I would say is that we should listen to the patient and we should make them keep a period journal because it's the first indicator that something might go wrong, that someone might have PCOS. We should examine the patient. We should check for male type alopecia, baldness. We should check for hair in the wrong place, in an unusual place. We should check for acne. We should check for signs of hirsutism. And then if we suspect polycystic ovarian syndrome, we should do a hormonal blood test. We should check the glucose level. And in case we suspect they don't ovulate, we should refer them to fertility early on. They don't have to have IVF. If we do an early referral and everything is good, we can treat them with just purely ovulation induction, and they will become pregnant. But before pregnancy, health optimization for the woman's own sake is much wanted. It doesn't have to be all about fertility. It's about our health as well.
I remember you teaching me that we should be referring patients much, much, much earlier if they have a background of endometriosis or PCOS. Are there any other conditions where that, like waiting 18 months or 2 years of trying to conceive wouldn't be appropriate?
The problem with the referral is that, I'll tell you from both sides. As an OBGYN registrar who has worked, when I used to be a registrar, I worked with many GPs, and I could see the strain and the pressure the GPs are under from all these people attending for, their own problem. For each patient, their problem is important, irrespective of whether I think it's a minor problem or a large problem or an important problem. For every patient, their problem is important. I think there's a lot of referrals, and the tertiary centers can't deal with them. There's not enough doctors to deal with the referrals, and there's not enough GPs to treat patients in a timely manner. But that's not why the podcast is here. However, I think that if we screened patients better in the community, then we would have to treat less patients in the specialized centers, and people would get a timely referral. But that comes back to what you said at the first 5 minutes of this conversation. If we train our primary physicians better, and if we try to make them understand what I know and what you know, then the screening would become so much easier, because you know that fertility takes two. It always takes two to tango. So if we screen the male partner as well, because we are talking about PCOS, endometriosis, women having problems, you won't guess. Fertility or infertility is 30% male factor, 30% female factor, 30% both. So if we screened males as well, that would make our job much easier. For example, a patient that does not have sperm, they are not going to grow sperm in the next 2 years when you have them at home trying. That's how life is. I'm not saying test them in the first instance. I mean, it's not how the system works. But what I'm saying is, if a woman is above the age of 35 and they experience 6 months of infertility, please start testing them. Don't just send an FBC, use an ease. These are useless. I don't care about your hematocrit. I want to know about your tubes. I want to know about your sperm. If you know that the CCG's criteria says that she's not going to get accepted to fertility, don't waste your time. Read the CCG criteria and don't send her to the fertility clinic. Give her alternatives.
When it comes to PCOS, we didn't mention any hormonal treatments. You said that, well, we did mention them. You said that they can mask the symptoms of PCOS, but it doesn't treat it.
No, it doesn't.
So does that mean that the treatment is like the metabolic side of things more than it is the hormonal side of things?
It depends. If you're asking whether polycystic ovarian syndrome can be treated, it can't. It's a genetic disease.
So you can't cure it, but we manage the symptoms.
If a woman has PCOS, she will have PCOS until she becomes menopausal. But as our egg count gets depleted, that PCOS will eventually turn into a normal ovary. However, the hormonal imbalance can be treated with the ways that we just mentioned. It cannot be cured, but by maintaining a healthy weight and all of these that we said before, we can regulate the cycle. The combined oral contraceptive pill, which is a bit ambiguous, people hate it or love it, and then hate it again, and then love it again. It is a first-line treatment for PCOS. It's not a cure. The combined pill helps regulate PCOS because it puts the ovaries to sleep. Thus, the ovaries don't produce unregulated androgens in excess. That means that the woman has a hormonal balance with taking the pill. It does not allow the ovary to produce imbalanced hormones, and that means that she gets a period every month. She maintains a healthy inside of the uterus. She has no risk for endometrial abnormalities, polyps, hyperplasia, and she can basically regulate her insulin as well. However, if you're asking me if this is the cure, it is not the cure. It is a treatment option that will help a woman avoid these acne scars. They will avoid having excessive hair growth, which is all part of an excessive testosterone that is being produced by the polycystic ovary. The combined pill is a first-line treatment. It is a treatment that is not a cure. If someone wants to do it the holistic way, because they might get migraines, they might have other risk factors and they cannot get the pill, they might have thrombophilia known in the family, they might have had VT in the past. So if you're asking me, if I had polycystic ovaries, I would try the holistic way first. And if my inositol or metformin or lifestyle changes did not help me, then yes, I would go on the pill.
Okay, perfect. That's really good to know. We've spoken a lot about balanced hormones and imbalanced hormones. And once again, there are lots of people within the wellness world who prey on women and talk about how all of their symptoms and any problem that they have is caused by unbalanced hormones. And then it can often be quite challenging when people come into general practice and they start telling us about their symptoms and they just say, my hormones are imbalanced and I want blood tests for my hormones. It's not always the most helpful thing, but often it can be quite difficult to explain that to the person in front of me. So how is, when you're talking about balanced hormones and imbalanced hormones, how is that different to what the wellness people say?
First of all, not everything that happens in our body is because of hormones, but there's a big correlation. We are complex human beings. Everything is connected. We are a well-adjusted machine. Yes, you can attribute a lot of things to hormones. Yes, it is known that a woman after the age of 40 has progesterone insufficiency because of abnormal ovulations. Her estrogens might rise and she might be estrogen dominant, or vice versa. There's a lot of things happening in our body. And the reason why we don't check hormones that often is because when you have hormonal imbalance, you might check levels on a Monday and they might be normal, and then you might check them on a Tuesday and they might be abnormal. So, and this is why all menopause societies would don't advise that you check for a blood test that frequently after menopause, because hormone levels are fluctuating every now and then and you can't have an accurate test. However, what I mean about hormonal balance, we humans express hormonal balance in ways that they cause a problem or an abnormality. For example, if a woman comes to me with vasomotor symptoms during her perimenopause, I know she's estrogen deficient. It is well known that estrogen, the lack of, will cause vasomotor symptoms, will cause hot flashes, night sweats. If a woman comes to me and tells me that I don't sleep at night or I wake up in the middle of the night, then I know she doesn't produce progesterone, because we know that progesterone helps relax the muscles and it helps us sleep better. But this is a medical capacity. It's not selling the dream. I don't do a blood test to see, on a random day that your progesterone is low or you're progesterone deficient. I might measure their peak day 21 progesterone if they have a 28-day cycle to see whether ovulation has occurred. But what differentiates a gynecologist from all these wellness specialists or a gynecologist trained in hormones is that you have to pick your battle. You have to pick which day of the cycle you're going to measure hormones and why you're doing it. Is there a fertility purpose? Is there a diagnosis purpose? Is there an abnormality in the cycle that you want to check? And then when we say hormonal imbalance, it doesn't have to be a documented hormonal imbalance. You can understand by treating the patient. I mean, yes, if a patient is very young and they don't have a period, I will of course measure their FSH and LH and try to make do with what I have, but I will measure it against international standards. So we know that if a woman has 2 consecutive measurements of FSH above the level of 40, then she's gone into menopause, irrespective of the age. If she's young, premature ovarian insufficiency. If she's old, it's called menopause. But by measuring hormones every 2-3 weeks and selling a blood test, that does not help guide us. Taking an accurate patient history and examining the patient, and based on that, ordering blood tests, yes, that will help us. If a patient doesn't have libido, I'm sure that if I check on a random day, her testosterone will be low. So it's a bit of knowing when to test and for what to test. And to do that, the patient has to give you their accurate history. What's the point of
That's
checking
really important.
FSH? when you're menopausal. There's no point. I'll tell you, it's going to be above the level of 40. It does not give us information on how to treat, on how to give HRT. The only thing I disagree with currently with the NHS is that we give HRT one size fits all. And this is something that I think in the future medicine, I said that before, will be individualized. I can't have the same amount of estrogen as my downstairs neighbor. It should be, I understand that it's a free service and they can't do it for everybody. But in the future, I think that it's happening in Greece as we speak. It's happening in other countries. There's clinics in London that do that as well. Yes, the NHS can't offer it, and we can all understand why. It would put it at a tremendous strain. And it's very lucky that it's a free service that you can visit the GP for free and get that service. But in the future, I think that we will progress to individualized treatment.
Yeah, I think I agree with you there, but I think that we're probably still quite a long way off that, particularly here. That was really helpful about the hormones, because you're right. It is completely different, and on a day-to-day basis, things change. It's like even your thyroid function. If you've had a cold or the sniffles or anything, your thyroid function just changes, and you have to repeat it again in 2 months. You mentioned that after the age of 40, you can get progesterone deficiency. I've not come across that myself. What is that? Because it doesn't sound. Is that a form of like perimenopause, or is it something completely different?
No. What I meant is that as we age, our hormones become what people call imbalanced. Is that there are women that will go into the perimenopause much sooner than the age of 50. And perimenopause might last 2 to 8 years, and you might find patients that might miss a cycle. That means that they don't ovulate properly, either because of their ovaries not working at 100%, they might be working 95% 1 month and then 100 the next month. But for women who might miss a cycle, or women who might get irregular periods, that means that they don't ovulate properly. Not ovulating properly means that you don't have an adequate amount of progesterone, and that leads to sleep disturbances, getting shorter cycles, getting mid-cycle spotting, you name it. Progesterone insufficiency can cause, but it's not a syndrome. If you're asking me this, if this is a medical condition, it is not. It is an observational result that we see for women who don't ovulate on a monthly basis.
Okay, fine. Yeah, that makes sense. I made a video talking about the supplements that women would need either pre-pregnancy or during pregnancy. And in reality, there's two. It's vitamin D and folic acid, which agrees with what you were saying earlier. I've also said that the current NHS guidance says that we should not be recommending any kind of high-dose vitamin supplement during pregnancy because there will be complications of that. And then I also said, definitely do not take something like cod liver oil or a vitamin A supplement because of the teratogenicity of it. But
Correct.
Someone's commented here saying, supplements to aid fertility, which ones are needed in pregnancy, thoughts on cod liver oil or vitamin A. So we've already addressed the first part of that. But someone else commented on a video saying that I'm completely wrong because my research is outdated, and they said that everyone can have cod liver oil and vitamin A supplements. Can you just clarify for the record, should people be taking vitamin A supplements or cod liver oil tablets during pregnancy or even in the build-up to pregnancy?
I will tell you, to my knowledge, and what I tell my patients, and there's always PubMed, which is the international library where doctors publish, and we can do a quick Google search. But vitamin A, if taken in large amounts, it is well established that it is teratogenic. However, if you see most cosmetic creams that have vitamin A, they have such a small amount that even if a woman were to take without knowing that, she wouldn't have a problem with her offspring. And this is because they contain very minimal, and it's a transdermal absorption, so it should not go directly to the baby. And if you're asking me, if it were for my pregnancy, I wouldn't take vitamin A. Not in a transdermal form, not in a cream, not in a pill. the acne regimens.
We would never recommend
What,
taking Roaccutane or any kind of retinol generally during pregnancy.
You can't. And you shouldn't. And my opinion is that pregnancy is a very short-lasting journey. It's just 9 months. Why risk it? You can take as much vitamin A as you want in the month to come, in the month before. Once you're a child and you stop breastfeeding, that's absolutely fine. But in my experience and in my opinion, I don't recommend vitamin A. Now, cod liver oil has a bit of ambiguous research, I would say. There's people supporting its use and people don't. I will say what medicine supports and what we know so far is that omega-3 fatty acids is the healthiest form of fatty acids that a woman should be getting in pregnancy. So if someone wants to get some kind of liver oil to support the brain function of their developing embryo, what they should be getting and what is recommended for them to get is omega-3 fatty acids and DHA. This is the form before the omega-3 fatty acids. And these two are highly recommended in pregnancy. I would say that if you do Google research on cod liver oil, you will find people saying, yes, you can take it. You will find people saying, no, you can't take it. So whatever is there and it's standing on the fence, I'm just purely saying to my patients, if it's on the fence and if there is even one study saying that you shouldn't be taking it because there were patients that reported adverse effects, would you risk it for your own baby? And I'm not playing with people's insecurity here. I'm just saying that during a pregnancy, I would want well-documented, evidence-based things for my baby.
I would want that for everyone in general anyway. And this is the problem I find with social media, is that people will look at, I don't know, a study or a trial that's been conducted on an animal, and they'll take one tiny little pathway, which has got no report, which goes then against documented outcomes in humans, and then they'll use this one little pathway, and then they will say, you need to change this one thing and your whole life will be fixed. And I really hate that, because there'll be no evidence in humans.
The problem with pregnancy and vitamins, medication, is what you exactly said. No pregnant population would ever say yes and would agree to participating in a double-blind study. And what I mean by double-blind for non-doctors means that one arm of the study, 20 pregnant patients, would be getting the potentially teratogenic medication, and the other 20 would be getting the nice non-teratogenic medication. There are no studies. It's unethical to do a study for pregnant patients with something that might potentially be harmful. So what we do is we test animals, and animals are not the same as the human body. So we don't exactly know how medication affects the pregnant population. We will never know. I don't think there's a sane pregnant woman that will say yes to a blind trial by giving her child something that we don't know how it works. So at the moment, what I would say is I advise all of my patients, and this is my first strategy, to use things that we know work in pregnancy, that they know they are beneficial. If there's something that is a bit contradicted or there's controversy around it, I don't recommend it. It's not essential. What is essential is that you take folic acid, 400 micrograms, unless you're in a special category, until 12 weeks of gestation. We know that folic acid helps us build a healthy spinal cord. It helps us avoid neural tube defect. We know that vitamin D helps us with the development of the brain of the baby. And that's it. Yes, some women might need iron, some women might need magnesium because they might have contractions. There's many women that will take vitamins, pre-pregnancy vitamins, like some brand ones. I'm not going to name them because they're all good and I don't have any objection to any of that. But if you're asking me what is essential is folic acid and vitamin D, and probably in the second trimester, some kind of iron supplementation if there's anemia, and omega-3 fatty acids.
Okay, amazing. What are the genetic factors that predispose someone to having a miscarriage? So I know about things like antiphospholipid syndrome, but what else is there? Because from my understanding, we don't really know enough about miscarriages. We don't know what causes them necessarily. Often it's that there would probably have been some sort of chromosomal abnormality, so the body terminates the pregnancy itself. But I think it's really sad that, what is it? It's like 1 in 2 or 1 in 3 women will go through a miscarriage at some point in their lives. And
Correct.
I think it's really sad that there's still a stigma associated with it. And people don't tell their friends when they're pregnant in the first trimester of pregnancy, generally. They wait until they've had their 12-week scan. So if they then miscarry before that, they may not necessarily have any support other than their partner. And I think that must be very, very difficult for people to have to go through. But are there any other genetic factors that might predispose someone to miscarriage?
So I'll just take a quick detour and stay where you said, women don't have any support apart from their partner. And that's something wrong. It should have been not your mistake. It's wrong for women to have that. It should be that they have support from their partner and from their doctor. But unfortunately, women might have a miscarriage and they will end up in A&E bleeding. And the doctor on call won't be able to provide that kind of support. And that's something really bad. Not bad, that's sad, actually. You should have the support of a health professional as well. You should be able to get an explanation about what's happening. You might not always get an explanation, but the fact that someone will spend some time with you to comfort you, to offer advice, to try to explain why this happened, that is something that every patient should be having. But I will not go into that. It's just that something that upsets me a lot, being female or having seen a lot of other females having a miscarriage. It's a loss, irrespective of if as a doctor, I know that the embryo is not fully formed and it might not even have a circulatory system or a heart. It's still someone's baby, although it might be the size of a peanut. Still, the peanut is important to someone. So there should be some kind of support, not just from your partner or from your immediate family. A healthcare professional should be able to spend at least 30 minutes with this woman or with this patient carrying that fetus to try and understand why this has happened and to try to not just empathize, try to help, actually help.
I agree with you. I think that there isn't enough support out there. I was at the Women's Health Summit back in January, which was hosted by the government, the Department of Health and Social Care at the Royal College of Obs and Gynae, and they said that they want to improve the support around birth trauma and miscarriages for women. I've not necessarily seen anything in practice yet.
It will be very difficult. It's the way the system is built, that you don't see a doctor when you're having a miscarriage. You might actually see the A&E nurse or someone who's not a specialized gynecologist. And it puts such a burden on the GP, who is not supposed to know why the miscarriage happened. I mean, we spent years in training and we still don't know why a miscarriage might happen. And we expect from the GP, who has to do with the whole body, to know why this happened. I mean, there should be a more individualized care for women undergoing this stressful experience. But I understand how the system is built. We have to make do what we have, or we can fight to improve what we have. And this is fundamental. But going back to your question, the reason why most women choose to let their family know that they're pregnant after 12 weeks is because most miscarriages will happen before the age of 12 weeks, the gestational age of 12 weeks, whereas only 1% of miscarriages will happen after the 12-week cutoff. And this is second trimester and third trimester miscarriages and stillbirths. There are many reasons why miscarriage might happen, known and unknown ones. There's immunological factors that we don't know. There's a reason why people don't have enough progesterone and they don't produce enough progesterone. And there has been a big trial in 2022 saying that there are women that might benefit from progesterone supplementation in their first trimester. And there's actually good evidence behind it. and in high dosages as well, from 800 to 1,600 micrograms. So that's a lot of progesterone. But genetic factors, we know that depending on a woman's age, the DNA of the follicle and of the forming embryo might be abnormal. So around the age of 39 to 40, 50% of the fetuses that will be created will be chromosomally abnormal. And then we also know that after the age of 43 years old, only 10% of the embryos will be normal. And after the age of 45 years old, only 5% of the embryos will be normal. So talking about genetic factors, age is the most important factor when looking into chromosomal abnormalities. And this is a key factor when consulting with a patient and telling them why miscarriage happened. Also, there are some mutations, some changes in the DNA that's called translocations of the DNA of the chromosomes. And this might also cause a miscarriage, especially if they are unbalanced translocations. That means that part of our chromosome has moved to another chromosome. And although the patient doesn't know they have it, they might pass it on to their developing fetus, and that might lead to miscarriage. There's also, as you very well said, the antiphospholipid syndrome, which is a thrombophilia syndrome that might cause recurrent miscarriages. It might also cause preeclampsia. It might cause stillbirths at 34 weeks. It might cause preterm labor. There's a lot happening with the antiphospholipid syndrome. We know that there's another thrombophilia with the PAI gene, the PAI gene, that might cause miscarriages. But all these factors, we don't investigate them unless a miscarriage happens again. And I know that it is very frustrating for a patient, but because it's scientifically proven that a miscarriage is most likely of chromosomal origin the first time it happened, and it might not happen again, there's a lot of people not testing. And the European societies and the British societies and the American society, all international societies, will say, depending on the country, that you need to test after 2 or 3 miscarriages. I understand this is a huge disappointment for the patient, but because these are costly tests, I think that countries have agreed that they should let patients get tested under the NHS or for its country NHS after 2 or 3 miscarriages. In the UK, 3 miscarriages. But from a female's point of view, it is very frustrating.
And it must be horrible, because even if, like, I suspect it becomes harder to deal with a miscarriage the later on, the further along in the pregnancy that one is. But even if it's at 6 weeks, you still would have had the excitement.
It's someone's baby. In Greece, because I've lived in both countries and I know both systems. I mean, in the UK as well, if you go privately, you can test for anything you like. But private testing is there for a reason, but also the NHS has guidelines also for a reason. I mean, especially if a woman is young, there's no point of testing after 1 miscarriage because it's very unlikely to be of chromosomal abnormality. It's very unlikely to happen again. And also, let's not forget, I'm very protesting, but let's not forget that testing also puts a big stress on the couple.
Yeah.
And some people might say, we're going to wait for the test results and we're not going to try for 6 months. That's not the way you're losing precious time. Yes, I'm very protesting after 2 miscarriages. I wouldn't wait for the third one to happen. I think it's a bit inhumane.
And I think that after a first miscarriage, it's something like 80 to 90% of women will be pregnant again within the next 18 months.
Exactly.
So yeah, you're right. It's not, I guess, in a world of limited resources, well, particularly in the NHS, where there's limited resources, we can't offer that to everyone. And I agree, it must be really frustrating. It'd be interesting to see if they bring it in after a second miscarriage, because that was another thing that they spoke about at the Women's Health Summit, was not waiting for 3 miscarriages before further investigations are done.
I think eventually the UK is going to follow the European Society's guidance, which is after 2 miscarriages, and take into consideration that, I can't have this happen to me for a third time before someone actually says, Maria, you have thrombophilia. Really? I had it from the first time I had the miscarriage. Why wait and take 3 valuable years out of my life to do that?
Yeah, that's a good point. Thank you so much for getting involved. I think we've had a very long discussion about everything gynae related and fertility related. So thank you once again. Do you have any final closing comments, or should we just leave it there?
No, it's been wonderful discussing all these things. I think that it's better sooner than later. The key to one's health, irrespective if it's about fertility, if it's about endometriosis, if it's about menopause, a woman's health and her right to bear children or to live a pain-free life should always come as a priority. And medicine in the past years and in the years to come will be about prevention. Test earlier, don't wait for something bad to happen for you to get tested. So that would be my advice to everybody. And listen to your body. Your body knows better, even from us.
Thank you so much.